welcome back to another episode of the Patient No Longer podcast provided by NRC Health. We have got a bit of an international episode today, and I'm really excited to welcome onto the podcast Hannah Fry.
Thank you very much for having me.
It's great to have you here, Hannah, all the way from Britain, and Hannah's got quite the resume. I'll cover a few of the many important points. She is a professor in the mathematics of cities at the Center of Advanced Spatial Analysis at UCL.
Rolls off the tongue, doesn't it?
That is a title I've never heard before, I have to tell you. And what you do there is you study patterns in human behavior, which I am so interested in applying to healthcare. But you are a mathematician, you're a best-selling author, and an award-winning science presenter, and you've done a few shows for the BBC.
I have, yes.
So one of those shows, I have to tell you, the one that really jumped out at me, was a program called The Joy of Data. Hannah. And I have to tell you, I don't often see joy and data associated together, so I love the title. But tell me from a healthcare perspective, and our listeners are often Americans in healthcare, and they look at data and say, oh no, that's another thing to add to my dashboard, or I'm inundated with data, I'm told to look at the data instead of looking at patients. And so there's issues with how, as an industry, we, healthy or unhealthily, handle data. What would you say to those folks about reinstilling or bringing about the joy in the data?
This is my whole tactic of how to operate, by the way, is take two words that don't naturally fit together in a sentence.
Put them together.
And make that your next project. That's entirely the way that I work.
That's a good tip.
Your maths of love, I think you're going to come back.
Oh, we are, yes. You're right.
Okay, joy of data. All right, so this program, I made it in about 2015 or so. So it was just at the point where there were an awful lot of devices and sensors out there in the world, but where people were still getting quite excited about the potential of them, of the types of different things that you could understand from them and learn from them. And I think that what's happened in the years since, the last few years, as you say, is that excitement has built to such a level that I think that people have kind of just taken this attitude of like, the more data, the better. Like sometimes I go and talk to companies and it feels a little bit like companies are sort of like, well, we know that there's good answers, there's good stories to be found within data. Mm-hmm. So let's just get all of the data. And then somewhere in there, in this like swamp, there'll be something interesting to find, like sort of greedy goblins kind of sitting on mountains of gold almost.
Big data. Remember big data was on the cover of Harvard Business Review. Everyone was using that phrase like big data. You're absolutely right.
Absolutely. But I think that actually, for me, the real joy of data lies not in the quantity, but in the types of questions that you can ask of it. So there's a really, really interesting insight by the Nobel Prize winning economist, Danny Kahneman, that I just absolutely love. And he says that humans have a habit of taking a hard question and swapping it for an easy one without ever noticing that we've made the substitution. Mm-hmm. And I think that a lot of the time, the struggles that people have with data lie in that fundamental mistake of making that switch. So I don't know, in cancer care, for instance, I think the really, really hard question that you want to be able to answer is, for example, whose life could be saved by cancer treatment, right? That's a really, really, really hard question. And I think that sometimes when data and technology enters the picture, that can end up getting swapped for different questions like, I don't know, in the case of medical imaging, which images have pixels that indicate abnormalities, right? And like in that swap, it's just get more and more and more and more data. You can lose sight of the original important question. So I think that for me, the real joy of data is about making sure that you are asking questions that data can actually answer and staying focused on what the prize is rather than just, drowning in the stuff without reason.
And the way that you say it, that way that you reorient it, Hannah, is so important because I think some of the joylessness of data comes from feeling like I answer to the data instead of the other way around. And what I'm hearing from you is we can take some control of that and have the data work for us and what we want to learn and discover and those things that can reignite some joy. And I think that's really important. So now I have to level up a minute and say, this is another phrase that I have to ask you about, and it's in your title.
Sure.
Advanced Spatial Analysis. Somehow I think this has something to do with healthcare, but I don't know what it is. So tell me, Hannah, what is Advanced Spatial Analysis?
Okay. In truth, I think person who set up the particular department at the university was just looking for a nice acronym about 30 years ago, and then just came up with
That would never happen in academics.
Absolutely not. Okay, so in truth, the things that I specialize in, when you look at the list of stuff that I've worked in, I feel like you're sort of inside the mind of someone who's just flitting about all over the place. So things like I've looked at the way burglaries are, embedded in certain parts of a city over others. I've looked at the way that riots spread. I've looked at, patterns of contagion, badgers as well, right? Badgers infecting cattle with TB. And all of these things feel like they're really, really different. But all of them include these patterns that move around in space and time. And so that really is my specialism. And when you know that and you see that, there are these mathematical connections that tie all of those stories together.
And it's so interesting how those events, different events, some negative, some positive, all tie together and the patterns can be similar. That gets me to, I have to ask you about one particular pattern, and that was COVID and how COVID spread. And you actually did a program for the BBC called Contagion. It was about a pandemic, and it was in 2018.
It was, yeah.
A full 2 years.
Yeah, 2017, 2018 we did it. Before pandemics were,
So I'm curious about that and how that informed you, but just specifically you as a person, what was it like to watch COVID unfold after you'd done a project like that?
Yeah. So the big idea behind the project, all of the experts knew that another pandemic was inevitable. I think another pandemic is still inevitable, incidentally.
Right.
But what we also knew was that when the next pandemic came, a key part of being able to predict its spread and to mitigate against its spread would be how good the data was in our models. And that data really depends on how people move around in space and time, right? Which is kind of my area of expertise. So, and crucially, it was about how far do people travel from their homes and how many people do they come in contact with. And at this time, in 2017, 2018, when we did this project, the best data that we had in the UK, the very best data that we had on that aspect of people's lives was a paper survey from 20 years ago that interviewed 1,000 people across Britain and said, hey, how many people do you reckon you met in the last week, right? It's got some good things about it. I'm slightly being tongue-in-cheek. But given that we had mobile phones, given that we have, wearable devices, all of this stuff, it seemed crazy to us that you would not have a much richer data set to draw from. So with the University of Cambridge, with the London School of Hygiene and Tropical Medicine, and then as part of my, I brought in the BBC as part of that collaboration, we did this citizen science experiment across the entire country. And we got 100,000 people to download this app, let us track them over 24 hours. And then in part, it was this sort of game. And looking back at the film, it's like we were being very playful in this sort of game of like a flu-like pandemic. So partly it was like, for entertainment purposes, but really the real reason was so that we could then use that data in order to inform the models when the pandemic inevitably came. But there were some freaky things. Do you want to hear some freaky things?
I do, yes, you have to share.
Okay, so that data did actually go on to be used in government models. So the thing is when we did this program, we had to decide on somewhere in the UK for the pandemic to start, right? For the simulation to start. So we decided that I would be patient zero, which I know is a controversial term, but for the purposes of TV.
Sure.
And we picked this town called Hazelmere in Surrey, it's just outside of London. It's kind of on the commuter belt of London. Okay. It's near to 2 airports, and it's also quite near the coast. So we were reasoning like, okay, this is like a reasonable place where the pandemic might start. So we set it all up, spent ages filming in Surrey, in Hazelmere, of me like wandering around, sort of pretending to, start off this simulated pandemic. Anyway, in 2020, when COVID hit, would you like to guess where the first case of domestic transmission was recorded in the UK? Like literally the same healthcare centre.
My goodness.
Sorry. So as a result of
That's wild.
Lots of like COVID conspiracy theorists have accused me of being part of the scamdemic, of course, and saying that we were doing a trial run, of course, for the real pandemic.
That did not come up in my research. It's not in your bio, and it. That's right.
But the thing is that so all of these people were saying like that was the reason why we chose Hazelmere because we knew that would be where it was.
Oh, goodness.
The real truth, right? We sort of post hoc rationalize that our argument, our rational reasons for why we chose Hazelmere. The real reason why we chose Hazelmere in Surrey is because the producer's gran lived there, so we had free overnight accommodation.
You could stay there. Right.
Yeah.
The personal connection.
Yeah. So
What an incredible coincidence, and also just seeing then everything unfold live, and you've been so involved in this and the patterns. I have to ask you a question about that with everything that you know about data. So another mistake that healthcare makes, at least in America, is that we look at our dashboards in totality and say they're completely representative of all patients. And we kind of surrogate it to the dashboard. And we miss out on a few things like human interaction that can't be really expressed in a dashboard. We also miss out on the people that don't use healthcare. So if they're not in our system, we really sort of ignore them until they are. And some of those folks need healthcare and are, for various reasons, affordability or convenience or whatever, they're not coming in. What do you say to people who are getting too sucked into the dashboard? I mean, as a mathematician, I'm really curious. How do we account for maybe things that aren't in the math yet or aren't in our patterns that we potentially need to add?
such a good question. So I actually wrote a New Yorker essay on exactly this idea, because I think that when you are dealing with data, when you're looking at the data that's directly in front of you, I think it's really easy to forget that it isn't actually a picture of the world that you're looking at. You are looking at numbers that are always going to be a proxy for the thing that you ultimately care about. And there is a gap between what you really care about and what you can ever possibly measure. And I think that unless you are careful to remember that, I think that that's where an awful lot of problems can really arise.
And that's so powerful because people don't realize, it's such a blind spot until someone tells you or you hear it or you see it. In your models, your advanced spatial analysis, I'm going to be careful not to wade too far in here and get into deep water, but in your models, are you constantly trying to adjust for that? Are you constantly trying to say, this is the way the pattern was, but it could change? I mean, because some people love to use data, but they want to kind of set it and forget it and say, well, we know this from a survey. You mentioned paper survey 20 years old. You're in the right industry to talk about that, because in healthcare, we love our paper and we love dated data. We love to say, well, I learned this 10 years ago and I'm going to consider it a fact today. How do you address that in your work, and what advice would you give people to shake that up a little bit?
Okay, so I think the biggest thing overall that I can say is that it has to be about intellectual humility. I think that a lot of time people obsess about making their models or their dashboards or their conclusions as perfect as they possibly can be, and forget that actually perfection is ultimately impossible, right? Like there's not this finish line that you get to cross. There's this really nice quote by George E. Box. He says, all models are wrong, but some are useful. And I think that by reframing things in your head of that way, of like, this isn't about making stuff as perfect as possible. It's about accepting that it's always wrong. And therefore, it's about continually committing to looking for and repairing and resolving the ways in which your representation of reality falls short. And I think that only by doing that can it's the thing that you were saying earlier about having the human right at the very center of this and having the data serve the human rather than the other way around. And I think that only by being kind of cognizant of both the power of data, but also very much its limitations, that I think that you can really, really make sure that the human absolutely stays in the center of everything.
That is so powerful. And what you say about intellectual humility, the piece I would add, observing people talk about data, is you can suss out pretty quickly when someone doesn't have intellectual humility about their data. And frankly, it works against them, because when they share that data, I'm looking for a reason to say that they're wrong. And so when you nail that, I absolutely love that. And we can all use a bit of intellectual humility no matter what. I want to take a little break from healthcare. It's always fun to take a break from healthcare. So we've got a new feature, Hannah, where we do a bit of a speed round, and you would be our first international guest for the speed round. And these are very quick questions, and I'm going to be honest, as I'm looking at them, they're a little oriented towards America. So if you've got a wild... That's true, but if you have a wild, different answer, we would fully welcome it. So these are just fast. I'm just going to hit you with it, top of mind. Coke or Pepsi?
Okay, Pepsi Max specifically.
Ah, Pepsi Max.
I have just read this book called Ultra Processed People, and it's basically put me off everything.
You're saying neither. Stay
Yeah.
away.
I mean, secretly at Pepsi, I'm Pepsi Max.
Yeah.
Some days when only a Pepsi Max will do.
I've had people say, why are you asking that question in healthcare? But frankly, it's a question everyone has an answer to.
Don't pretend that you don't drink it. Come on.
Yeah, it's about being authentic here. Thank you, Hannah. Okay, so next one is, in terms of reading, fiction or nonfiction? You're a reader.
I am. I really am. I just did up my house recently and have only just unpacked all my books. And there are, I would say, not exaggerating, 20 bookshelves of nonfiction and one single shelf of fiction. Honestly, it's pathetic. It's pathetic. And about half of them about dogs.
I love that.
Yeah, nonfiction.
Okay, yeah, the library doesn't lie. Okay, morning person or night owl?
Oh, neither. Nap in the afternoon person.
All right, we could throw that in. We could add nap in the middle there.
It's I think Newton's law of motion, that an object at rest stays at rest and an object in motion stays at motion unless subjected to by an external force. That, I think, is the ultimate description of me, right?
Yeah.
Which is that moving between states is very difficult. But I mean, night owl, so I was up till like 3 o'clock in the morning last night just working.
And adjusting time zones and doing all the things you do.
But yeah, so neither and both.
Okay. This is a very American question, but I'm going to pose it and then I'm going to give you a British version.
Sure.
Boston or New York?
I have an answer.
Go for it.
Believe me, I have an answer.
Okay.
Okay.
I'm on the edge of my seat now.
Okay. So there are. Oh no, I don't know whether to be honest. Let's be honest. Okay. I think there are some amazing things about New York. Right?
Sure.
But the thing about New York is that I think New York's a little bit lacking in intellectual humility.
Maybe so. You said that very kindly, but I know what you mean.
New York is a little bit like they just maybe need to go and visit some other cities because there are other great cities too. And so I think Boston is New York, has all the good things about New York, most of them, but without the rubbish bits.
Yeah.
Boston for me.
The rubbish bits. Yes, that's true. That is true. Okay, this so your favorite city, and maybe we got some folks thinking about traveling to the wonderful United Kingdom and to Britain. Favorite city to visit in your home country, Britain? What's your favorite city to go to?
Okay, Bristol.
Bristol, okay.
Yeah, it's really beautiful. It's sort of built on this waterways. There's loads of little islands right in the middle of the city. I mean, it's like there's kind of land all around it, but as the river sort of meanders through, there's loads of little pockets. It's also this very, it's got this really strong industrial history and just beautiful, beautiful buildings, really great food, and it's not arrogant like London is. So I think Bristol is the Boston of the UK.
I love that. Okay. Well, there you go. And last question, favorite TV show of all time? This has been stumping people too.
Favorite TV show of all time? Oh my gosh, that is so hard.
You can substitute favorite movie if that's an easy.
I think I'm going to go for the one that I've watched the most times.
Sure.
Over and over and over again, which is the original versions of Sex and the City.
Okay.
It's like my comfort food.
I love that.
The modern stuff is, I mean, it's a poor imitation.
I haven't checked it out yet, but I'll.
Honestly, save your own time.
If a mathematician tells me to stay away, then I will. Let's stick with Britain for a second, because in America, whether we're holding a conference or we're speaking or virtual, wherever, this is often a question that pops up in America. Why don't we do things more like the UK or more like Europe or even more like Canada, our neighbors to the north? Do you see those differences, and how do you see those differences from your perspective coming over to here from Britain? What do you observe in American healthcare?
Yeah, okay. My gosh, the differences feel very stark. It feels like almost in the entire world, America is at one extreme, Britain is right at the very opposite extreme. And I think that both have their merits and faults. But I think that they're very, very different. So I think the big thing in the UK is that it's about you're treating at a population level. And I think that you really feel that actually acutely when you're in the system. So there is a phrase which is that the NHS is good at births and deaths and nothing in between, which I think is kind of true.
Yeah.
You know, if you are an amputee, for instance, and you need something that is extremely tailored to you, you know, something that is absolutely perfectly constructed around your particular needs, I think that you struggle, actually, I think, in the NHS. I think also there's a lot of stuff, actually I'm going to be talking about that at the conference this afternoon. I think there's a lot of stuff about side effects of radical interventions in cancer care, for instance, where I think in the UK you know, where I think that actually the sort of long-term implications of things aren't necessarily at sort of front and center in quite the same way as it would be in the US, because again, you really are ultimately prioritizing the population view, and then, you know, survivability is the key metric.
Of course.
I think in the US, I do think that the patient experience, like the patient is front and center of things. It's much more about the patient as a consumer. This is my impression of it.
Of course.
Which I think can be a good thing, but I also think it can be a bad thing.
Yeah.
You know, I think that actually sometimes I think there is a tendency to overtreat, I think, when you put the patient at the center of stuff. I think sometimes, you know, this is a film that I made actually about end-of-life care and cancer. And I do think that sometimes actually having a system that says, that supports you in being realistic about about how you balance quantity and quality of life, rather than saying if you have the money to pay for it, anything is possible. I do think that there is a slight advantage, or there can be a cruelty in hope, I think, sometimes.
Sure.
Which I think is an extraordinary statement to say, and I realise I'm not caveating that as eloquently as I could be, but I also think that the big thing that's noticeable from the UK side is about how, if you are lucky enough to have good health insurance in the US, I do think you get exceptional care, better than you do in the UK actually. But I also think that if you are not fortunate enough to have good health insurance, it does feel really extraordinary that you can live in a world and in a country that is quite so rich, where people really do get left behind with healthcare.
And it is a shame, and it's something that, you know, America is working on, and it's a long slog, but there's inequities that we absolutely have to fix. And I really appreciate your honesty around when you put the patient at the center. Everyone's afraid to talk about potential downsides of that because we say patients first. And I had a recent guest on, Brandon Jones, who said, patients first, it sounds good, but what about our workforce? What about the people in front of us? And frankly, a rallying cry like that, it doesn't replace that individual situation where you've got a patient in front of you who needs you. You've mentioned cancer care a few times. And so I want to ask you this because you had a personal experience as a patient in cancer treatment, and share whatever you're comfortable with. But I'm curious how that personal experience, how it went, and then how it's affected your professional career as well.
Yeah, the connection between two is really profound. So I was diagnosed with cervical cancer when I was 36, and I had very radical surgery. There was a real concern that it spread to the lymph nodes. So I had all of my pelvic lymph nodes removed, which is like quite an aggressive treatment. And has had, you know, long-term repercussions. And I have lymphedema, which is this chronic condition where you have swelling in your limbs, you have to wear compression garments and all of that kind of thing. Now, the big thing for when I was diagnosed with cancer is that I spent my entire life thinking about numbers, right? Like my entire life talking about risk and uncertainty and probabilities. And all of a sudden, when those numbers are about your life, right? Everything looks so different. I suddenly realized that I had no idea what 90% means. Like I genuinely, I mean, intellectually, of course, I can write you 1,000 definitions if you like.
Sure.
But what does it actually mean to say you know, there's a 90% chance that this will happen. It's genuinely meaningless. And I think that I ended up thinking a lot and continue to think a lot about that translation between a population level number and what it actually means for an individual and how you communicate that, particularly at a moment when someone is in real, genuine crisis. I think it's a really difficult question.
It's a difficult question, but that is such a powerful juxtaposition. And I've been in the same experience, not with that sort of treatment and the journey you've gone through. And we're so glad that you're back and you're with us and you can share that story. But that is what happens to the patients. For them, the numbers just fall off the page. And it's about life and death, and it's about my future and getting back to who I am. And it can be so tough from the other side of that as a caregiver to put yourself in those shoes and to think about it in that perspective. You have another great juxtaposition of words that I have to pick on. Not even pick on, just know more about, because you're so good at this. The mathematics of love. This is another thing that I don't think most people, when they imagine love, I don't personally think about mathematics. And when I think about mathematics, it's not something I love. So I have to ask you, what this program that you've done in mathematics of love, tell me what it is.
Okay, so this started off as a very silly private joke.
Okay.
That just got terribly out of hand.
The best things start as private jokes.
So obviously, I mean, I am like mathematician to my core, right? Like if you cut me open, I would bleed numbers. And so when I was younger and dating, obviously I had a whole series of mathematical strategies to optimize my own dating life, obviously. So I put them together in a TED talk that ended up going super, super viral. It's the reason why I ended up getting shows on the BBC and so on.
Of course.
But I would also say I got in quite a lot of trouble for this, because while the strategies are mathematically optimal, I mean, you cannot avoid uncertainty, right? And so even the best of these strategies, they only work like 37% of the time, which means that they do not work
63%. I can do that math. I can do that math. That's wild, yeah.
Yeah, and so lots of people were very angry with me for saying that they broke up with their partners because I told them to do so.
I think every great idea gets at least a few people angry. If you're not getting a few people angry, you're getting
2/3 of them angry.
I love that we could at least come to a close on math that I can use, that I can actually do personally. I have to ask you one more question, and I always pose this at the end, and it's not in the script, but I think it's a really powerful one, and I'm really curious about your answer. You bump into someone, whether it's here or when you're back home, who has started their first day on the job in healthcare of all industries. So they're day one of their first day in healthcare as a career. As a mathematician, with all the things you've done and thought about, what's a piece of advice that you would give that person? Let's say you're in an elevator with them. What's a piece of advice that you would share with them as they start their journey in healthcare?
Okay, there's a really nice quote, which is that medicine is a game of a science of uncertainty and art of probability. And I really think that's true. I mean, I think that there is obviously so much outside of the numbers, right? But I think that you have to get comfortable with the uncertainty of it all. And I think that what I see from the outside as a mathematician looking in, I don't think that there is a culture of accepting the uncertainty, either within patients or often within the healthcare profession itself either. And I think that actually sometimes when you know, it kind of goes back a little bit to what we were saying about intellectual humility before, right? I think if you pretend that uncertainty doesn't exist, if you don't have intellectual humility about your own decisions, and if you expect perfection rather than committing to continually improving, then I think actually you're not going to be the best doctor that you can be.
That's powerful. I mean, the science of uncertainty, the art of probability. I love the way you say that. I think someone would.
It's not my quote, by the way.
Sure, but the way that you would apply that in an elevator, that other person would be very beneficial in riding an elevator ride with you, Hannah. And I think they would use that advice. And I've benefited greatly from having you on today. This is a fantastic view that you have, and it's very unique. Thank you so much for sharing it with us.
Thank you so much for having me.
And that concludes another episode of the Patient No Longer podcast. We will talk to you again soon.